Mode.
And welcome to our webinar, Building a Simulation Alliance. My name is KT Waxman, and I'm the Director of the Masters in Healthcare Simulation program here at University of San Francisco. And I believe this is the fourth or fifth webinar in our series. We have one more scheduled for January, and this one will build on some of the others, and it will be a brief overview of what a simulation alliance is and why it's important. And then I'll talk a little bit about the program for our master's in simulation. Let's see if I can get the next slide. Went too far. So the objectives are to list the essential components of a simulation alliance, compare and contrast simulation alliances around the U.S. and abroad, discuss why building an alliance is so important, and articulate some trends in simulation alliances internationally. The webinar will provide participants with information on building a regional or statewide alliance. We will review program goals, stakeholders, sustainability, and discuss best practice models in the U.S. and abroad. So I see that we have quite a few people signed in, and of the people who have signed in, I recognize some of the names as some of our students that will be starting in a few weeks. So that's great. Welcome. I'd like to talk briefly, for those of you who haven't been on any of our webinars before, on what is simulation and why is it important. And then I'll move into building an alliance. So simulation really is the imitation or representation of one act or system by another. And this is a definition by the Society for Simulation in Healthcare, SSIH.org, one of our resources. The purpose of simulation, there are really four. One is education, the second is assessment, the third is research, and the fourth is health systems integration. So I'd like you to start thinking about building an alliance, a regional or statewide alliance, and how these four main purposes, according to the Society for Simulation in Healthcare, actually fit in to an alliance and the structure of an alliance. And when we talk about some of the alliances around the country, you'll see how these four components fit in. So there are several types of simulation. And I can tell you that as the director of the California Simulation Alliance, when we started out our alliance, we really were focused on high fidelity simulation. And we have evolved over the last 8 years to really defining simulation as multiple modalities and multiple methodologies, including computer-based simulation. You can just do computer-based simulation and not have any high fidelity mannequins. So computer-based really is focused on, for the student or the learner, to do some work on a computer with avatars or what have you before they move into doing some hands-on with high-fidelity simulators. High-fidelity really speaks to realism. How real is the mannequin or the standardized patient? Because if you look at a standardized patient, which is the fourth bullet there, that is a person who is actually trained in being an actual patient in a simulation with symptoms. They're scripted to say certain things, ask certain questions, and really, in reality, that is very high fidelity. But we often think of high fidelity as a mannequin in a bed. So high fidelity includes, from a mannequin perspective, all those bells and whistles where they're breathing, there's bowel sounds, there's breath sounds, there's pulses, etc. Whereas low fidelity could be a Recessa Annie, could be a vital sim, or a simulator that doesn't have all the bells and whistles, or it could be something that you've set up in a room with your own speakers, with your own devices, and so it doesn't have to lend itself to being a very expensive mannequin. But low fidelity is often very used widely when you're doing team building and collaboration. You don't really need all those bells and whistles. Standardized participants I spoke about, they're being called standardized persons, standardized patients. These are actors that are scripted, and most of the time they are paid or they are volunteers. We're seeing a lot of standardized participants in retired nurses and physicians giving back to the community and acting as patients. A hybrid would be a combination of high fidelity and a standardized participant. And an example is an OB simulator where you could have the baby being birthed out of a prompt, OB prompt, and then the mother at the top of the bed is a real person. Immersive, when we actually put people in an immersive experience just like they're in the real world. In situ, where their activity takes place in the patient care area or the lobby or the parking lot, but it's in situ, it's not in a simulation center. Mobile simulation is really growing and getting a lot of press recently with vans that are loaded up with simulators and faculty, and they go out specifically to the rural areas where they need education on high risk, low volume events. Virtual reality, things like CliniSpace and Second Life, where you're actually in a virtual space doing interesting scenarios. The Cave is another example of virtual reality where you're walking in to an empty room and there's holograms and there's sounds and smells and avatars and simulators and people, and it mimics being like in the battlefield or in a specific event like an active shooter. And so those things are getting more popular. So with all these things in simulation and everyone doing all these things, it's really good to come together to build a collaborative or an alliance to share best practice. We're finding that simulation is being utilized primarily in schools, and schools is where it really all began. Schools and the military. Hospitals followed suit, and they have really increased their use of simulation in hospitals. We're seeing it being used in the communities, in clinics and surgery centers, and in the battlefield as well, all over. So it is not really about the technology, it is about the methodology. And so with that, we need to really identify who's using simulation and who are our stakeholders. So when you're thinking about building an alliance, and you may want to start with just 2 or 3 schools, 2 or 3 hospitals, a community, a region, take a look and see who's out there using it. And primarily, you're going to look at hospital educators, academic faculty, make sure that administrators are at the table, your sim techs are critical, and always invite your vendors. Make sure that your vendors are at the table. They have a lot to offer. So what is an alliance? It's really just a group of people coming together for mutual benefit with mutual goals. So this could be extremely grassroots where 5 or 6 people are sitting around the table, maybe at a simulation conference, saying, hey, I live in your area and I have a simulator and I'm doing it this way. Someone else says, well, we don't have a simulator yet, but we're using standardized patients. Why don't we get together and share how we're writing our scenarios, how we're working with vendors, how we're educating, and that would be the beginning of an alliance. So why would you want to do this? It's really to bring people, simulation users, together as a community. And I tell you, this is my first experience. I've been in healthcare for over 30 years, and this is the first time in the history of my career that I've really been involved in an industry that is as transparent and sharing as the simulation industry. When I worked in the hospital and I had a great policy or procedure, I held on to that very tight to my chest, and I didn't share that with others because it was my work. Whereas now in the simulation community, especially within these alliances, if someone has a great form or policy or template that they have created, they are open to sharing it with others. So it's really bringing people together and standardizing the way you work. So if you have one form and I have another form, can't we look at standardizing the form and maybe use mine as the template, and then over here at this school or hospital you could work on a different template or form. The sharing of resources is also critical. Some hospitals, if you're in a hospital, you might relate to this, that there may be an area in a medical office building or an old nursing unit that's not being utilized anymore, or it's shut down for lack of patients, or it's just not seismic safe according to the law. And you could put a simulation lab or a center in that area. And then consider your community college or your university that's in the neighborhood who might not have any space at all, yet they're eager to do simulation. So sharing of resources, they might want to come over to your sim center and do their training. What would that do for you? You could recruit from that pool of students. You could orient them in the hospital setting before they get to the unit as a student or a staff. So there's lots of opportunities for sharing. We've also seen sharing of simulators. If somebody has a very high fidelity, expensive high fidelity, and that someone else has an OB simulator, they may do a trade-off and share resources if they live in the same community. I've also seen sharing of staff where a simulation faculty might have a dual appointment in both the hospital and the school to educate both staff and students. And it can also pull the community together to help prepare for accreditation. It can also provide education for their constituency, and I'm going to share some of those learnings and what's happening with many of the alliances around the country relative to education. So there's a couple of examples. Now there are, at last count, and I did some research on this, there were probably 42 simulation alliances in the United States, and those are only the ones that we could find. But I'm going to highlight just a few, just in the interest of time. The first is the California Simulation Alliance, which I'll save for the end because I know the most about that one. Florida Healthcare Simulation Alliance on the other side of the country. Tennessee, Hawaii, and the Victoria Simulation Alliance, which is in Victoria. This is a province or a state in Australia, and it's based out of Melbourne. So the Florida Healthcare Simulation Alliance, their mission is to advance, coordinate, and expand the use of all forms of simulation in academic settings, healthcare institutions, and agencies across the state to advance healthcare education to ultimately foster patient safety. It serves as a resource to facilitate collaboration, networking, and the development and integration of best practices into the delivery of patient care and to improve patient safety. It's a very grassroots, membership-driven organization. Now, 2 times in this mission statement, they spoke to patient safety. And that's one thing I'd like you to keep in mind if you're forming an alliance, is the bottom line that we're doing simulation has to do with patient safety and patient outcomes. So we cannot lose sight of that. Whether you're working as an EMT, as a physician, as an RN, it doesn't matter. That is why we're doing simulation to begin with. The Tennessee Simulation Alliance, their objective is to enhance nursing faculty capacity to use educational informatics and simulation technology. So they have a shortage of nursing faculty, and they're using these methodologies to increase faculty capacity. So they can either take on more students using sim or recruit faculty as well. They've also developed, as a result of consensus among nursing leaders in the state, these initiatives. In time, other professions expressed interest and engaged in interprofessional activities. So both Florida and Tennessee are not strictly nursing, they're interprofessional. Florida has 5 or 6 regions right now around the state, and Tennessee, I believe, has 2 regions. they've had some initial conferences based on a needs assessment, and they started with nursing because they had some grant funding for nursing, and then they have evolved into interprofessional. And they've had conferences based on that feedback. Oregon Simulation Alliance is the oldest statewide alliance in the country. In 2002, the OSA was started as an initiative out of the State of Oregon Governor's Office to improve healthcare delivery and increase the number of healthcare providers with the use of medical simulation technology statewide. And I know for a fact that they started out just like California did in terms of looking at technology. And see, that's in this statement, because back in 2002, it really was about the technology until we as an industry figured out it's really about the pedagogy and the methodology of simulation. So Oregon was the first statewide alliance in the country, and the California Simulation Alliance was modeled after the Oregon Simulation Alliance. Their mission and vision in Oregon, and remember, this is a fairly small state, so there's a lot of rural areas in Oregon and a couple of big cities, but they want to ensure quality patient care for all Oregonians through the use of simulation technology and practice to help healthcare workers to be more confident, competent, and compassionate in providing patient care. So they don't say patient safety there, but they're speaking about patient care. The OSA is a 501c3. Now, a 501c3 is a nonprofit organization. Each of these alliances is different. Oregon is a standalone 501c3. Tennessee, I believe, sits at one of their colleges. For now, I'm not sure that they are a 501c3. And the Florida Healthcare Simulation Alliance sits at the state's Nursing Workforce Center out of Orlando, and it is a program of that organization, which is a 501c3. And then we have Hawaii. And in 2010, Hawaii started. They formed a steering committee. They got commitment from both education and practice. And it's a small state. They have 9 schools of nursing. They have 1 medical school. And their major medical centers are on Oahu and the neighboring islands. So they started with pulling people together. They have a big simulation center at the University of Hawaii at Manoa, and they have a big sim center at the medical school there as well. So they were sort of the hub, and they brought people together, and you can imagine how geographically challenging it might be for the folks on the other islands to come in for meetings. So they are in the early stages. They have academic institutions, healthcare agencies. They have industry partners, which they were really, really good about bringing the industry partners on early on, that are all committed to optimizing the state-of-the-art technology resources to better serve the people of Hawaii. So they've pulled together, they've done an inventory of the technology that's out there in each school and hospital, and pull people together to share resources. They want to align education and practice to improve the quality and safety of patient care in the state of Hawaii through the use of innovative healthcare simulation, information technology, and research. So again, it's patient care safety. So those are examples of about 4 SIM alliances around the country in the U.S. I'm going to talk a little bit now in more detail about the California Simulation Alliance, which began with the Bay Area Simulation Alliance. It's actually the Bay Area Simulation Collaborative, the BASC. And the BASC was funded almost $1 million by the Gordon and Betty Moore Foundation from 2006 to 2009 to achieve 3 outcomes: faculty development, scenario development, and research. And like the other alliances, we established a governance structure, we established processes, and became a demonstration project for other areas of the state. A good reputation was established, partnerships were formed with key stakeholders, and we started off by having members of both service and academia. And so from '06 to '09, the Bay Area Simulation Collaborative, which was funded, was built to be a demonstration model. It became very credible. It created a sense of community and standardization in the Bay Area, the San Francisco Bay Area. And it actually paved the way for the launch of the California Simulation Alliance and other statewide simulation collaboratives. So the Bay Area, to give you a perspective for those of you who are not in California, the Bay Area consists of probably a 100-mile radius. If you look at San Francisco and go maybe 50 miles either way, except if you go west, you'll be in the ocean. So if you just picture that, there are about 65 hospitals and 35 schools of nursing in that area. And if you look at Oregon, the Bay Area was probably the same size as the entire state of Oregon. So the Bay Area Simulation Collaborative, built on Oregon's learnings, became a demonstration model, but it wasn't a statewide alliance, it was a regional alliance or a collaborative. And so it paved the way for the launch of the big statewide initiative. And California currently has about 37 million population. We have over 400,000 registered nurses, 110,000 physicians. We have 8 medical schools. We have 145 schools of nursing. And it's a big state. It's about the size of Florida, but I think our population is bigger. And so the Bay Area Simulation Collaborative came together and said, what can we focus on to bring all of these stakeholders together? Well, the main thing was faculty development. We wanted to train as many people as possible on how to teach in a simulated environment. And so they created this model, which has been published in multiple journals, of a level 1 through 4 train the trainer model. And the first 2 levels are your basic training and the simulation methodology. It was built on a novice to expert model based on Patricia Benner's theory. And the theory really says that once you move into simulation, regardless of how many years of experience you have under your belt, you're still a novice. It's a different way of teaching, and there's a lot to learn. So people go through a series of courses from level 1 through 4, ultimately ending up trainers themselves. So the first couple years we were really focused on this level 1 and 2, getting people safe, advanced beginner. We didn't want people out there doing simulation and doing a lot of talking. We want the students and the learners to talk. We want it to be safe so that the students feel it's a good experience and they walk away at least learning something. And then the California Simulation Alliance, which was launched in 2008, took that same model and worked over the next couple years on really building competence. Level 3, we have an apprenticeship program, which I'll talk about a little later. Specialty courses like simulation leadership, technical training, debriefing, discipline-specific training. So we're building strength, we're building competence, and at the same time on the right-hand side, you'll see the scenario development was occurring and writing scenarios that were going to be shared with others. And to date, I believe we've disseminated over 3,000 to 4,000 scenarios all over the world. When we were grant funded through the BASC, all of these scenarios were free. We're looking at a different model now since we're moving into sustainability, but we've disseminated quite a few around the world. So 2010 to 12, we focused on building competency. And then for the last 3 years, looking at going into next year, we're really focusing on building expertise and training as many trainers as possible. We now have trainers in San Diego, in the Inland Empire, in Los Angeles, Orange County, in Fresno, in the Monterey, Santa Cruz area. We have Sacramento, we have San Francisco, and then we have the far north. So we have trainers all around the state. So currently, this alliance, which is a virtual alliance, which sits at Health Impact, which is formerly known as the California Institute for Nursing and Healthcare, is our state nursing workforce center, just like Florida. And it's a 501c3, and the CSA is a program of Health Impact. We have trained over 2,000 faculty from hospitals and schools since 2007. And then these apprentice sites that I mentioned, we have 2 in Northern California and 2 in Southern California. We purchased that apprentice curriculum from the Sim Health Consultants up in Oregon, and that curriculum has been implemented at Stanford, at Samuel Merritt University, Loma Linda, and Little Company Marion Medical Center. We've had 16 apprentice graduates to date, and we have 2 that are in progress right now. They receive a certificate of completion, and the apprentice program is 72 hours long. So after you've gone through a couple of the first level 1, level 2 courses within the CSA curriculum, you can move on for an apprentice experience. So this alliance really focuses on conducting educational simulation courses to prepare faculty to teach utilizing simulation, and to enhance and foster the development of simulation as a modality for transforming healthcare education. This alliance is the hub to maintain best practice models and share those amongst the state and for their subscribers. Learning about how to integrate simulation into curriculum for both hospitals and schools is also a best practice model, and we share that as well. We also conduct interorganizational research. We have a research committee, and we have one of the chairs is at UCLA and the other is at Cal State Fresno, and they have done an inventory of what research has been completed in the state of California, and we're hoping to do more interorganizational research. They've helped us facilitate several surveys that have been conducted throughout the state of California over the last 5 years. I think one of the most important things that this alliance does is connects people and facilities. If someone's new to simulation, all they have to do is email us or call us, and we will connect them with people in their area and resources that they need to get started. The CSA also negotiates contracts with vendors for pricing agreements. So they currently have about 7 pricing agreements with vendors. So if you're a subscriber to the CSA, you get a discount on simulators, equipment, etc. They're also the voice for simulation within the board, with the Board of Registered Nursing in Sacramento, which is our state capital. And I will talk a little bit about the NCSBN study, but it's important to have a unified voice when you talk to boards of registered nursing. Here is an example. It's kind of blurry and it's colorful, but you can see where we have 7 regional collaboratives that have emerged in California. We really anticipate that Southern California will emerge with a couple of additional collaboratives since the LA region is so vast. The last alliance that I'm going to speak about is the Victorian Simulation Alliance. And Victoria, if you look at a map, I have one coming up here. So this is Australia, and the red area is the state of Victoria, and the red dot is Melbourne. And Melbourne is the hub for the VSA. Now, to give you an idea of how we have all been sharing resources for many years, is that Florida asked us to come from California to Florida to share our story, and so they built out some of their alliance based on some of the learnings from California. Victoria replicated the California Simulation Alliance in Victoria. And the logo, as you can see, the VSA, this particular college in which the VSA sits has a wonderful graphics design department. And so they asked them to develop a logo, and they came up with 3. They chose this one. The one that they didn't choose, they gave to the California Simulation Alliance, and they changed the V to a C, and that's how we got our logo. That's just a little sidebar, but it just shows how we share. They were founded in 2010 to support the ongoing implementation of simulation into health professional education and training across the state. And they want to provide a health professional educators with a community of practice around simulation. So you can see we have some themes going. It was modeled on the BASC and the CSA. They want to create an environment that fosters collegiality, collaboration, networking, and sharing among those engaged in health professional simulation-based education and research. 4 areas are priorities. One is communication, the other is education, scenario research development, and collaboration and research. So that's an example of 4 or 5 alliances in the country. Many of them are grassroots. They came together and then evolved from there. Others were grant funded. I don't feel like there's a lot of grant funding available to create alliances out there, but if you dig deep within your foundation or with some of your local funders, you might find money that would allow you to create your own alliance based on the evidence that we already have. So what's the purpose of an alliance, and is simulation really here to stay? So what we found in our surveys that we did in California is 98% of the schools are using SIM and 87% of the hospitals are using SIM. So yeah, it's here to stay. We conducted 4 surveys over the last 4 years, and this paper is in the process of being published. Looks like most of the students that are benefiting from simulation are RNs or LVNs. We're moving into interprofessional, so we've got EMTs, respiratory care, medicine, and pharmacy as well. We asked, how did your school utilize simulation as a teaching method? Many are using high fidelity, some mid-level fidelity, role play, which is a form of simulation, standardized patients, computer, and virtual reality. We asked hospitals what type of simulation they're using, and they have high fidelity, mid-level role play, and you can see that they're primarily looking at high fidelity and mid-level as their biggest use of sim. We asked schools why they're using simulation, and most of them are using it to develop clinical judgment, support and anchor the application of theory, and development of professional communication skills. Some are actually using simulation to develop the QSEN competencies, which is a quality safety education for nursing. Hospitals are using it primarily for uncommon clinical experiences or events, and also development of clinical judgment. So that study that I spoke about is another reason to form an alliance. The National Council of State Boards of Nursing research study that has just been published took 10 schools around the country, 10 schools that were not using simulation. And the first year, they changed the curriculum to integrate 10% of their clinical hours in simulation. The second year, 25%, and the third year, 50%. And in terms of outcomes, the outcomes showed that there was no difference in their NCLEX scores whether they used 50% simulation or 100% clinical experience. So they took students that had no experience in sim, no sim at all in their curriculum, 100% clinical, and another group that had 50% sim. And their outcomes were the same. in terms of passing the NCLEX, which is the national board exam to become a registered nurse. They also found that 2 hours of clinical experience equals 1 hour of simulation. So what that shows you is that you can get bigger bang for your buck in simulation. You can guarantee a clinical experience, and it equates to at least 2 hours of clinical. So an alliance could get together to take this data and share it with their Board of Registered Nursing, create a plan around either coming up with a 50% simulation regulation or increasing what they have. I know in California we have 25% simulation. That is the max that we can do according to our board. We are working through our alliance to work with the Board of Registered Nursing to increase that to 50%. So is simulation here to stay? Where is the evidence? And why is this important? Since there were no difference in outcomes for students, that is evidence in and of itself. Faculty development is critical. You can't just buy a simulator and hope that simulation will happen. You have to train the faculty to be able to facilitate simulations. Studies show that with simulation in hospitals, sepsis rates have decreased, transfers to ICU have decreased, and teamwork has been enhanced. So yes, it is here to stay. We do have evidence. Faculty development is critical, and an alliance can work on this very topic. The CSA is really committed to training as many faculty as possible with a standardized curriculum. Other states are doing the same. It is critical for the success of a simulation program. It's focused on methodology grounded in adult learning theory, and it also prepares the faculty for certification and accreditation. So alliances can form together to standardize this curriculum so that regional faculty can get their certification. It ensures that faculty have necessary skills to develop appropriate scenarios and teach in the simulation environment, and it really does need to be budgeted for because it is often overlooked. So some strategies for building a successful simulation alliance. First of all, have a plan. Map out a plan. Where do you want to go? Why are you here? Try to get some funding behind it. There may be a vendor that might want to fund an initial meeting and pay for lunch. You may have a college or a hospital that can host a meeting to get you started. When you do set up that meeting, you have to have the right people at the table. So who are your stakeholders? Make sure you have the right people there. That group can develop a mission statement, agree on common goals, and then start scheduling some meetings so that every month you have a meeting to talk about the evolution of your alliance. Agree on a name, and then start networking with other alliances. That is critical. So some resources, and if any of you are attending the International Meeting of Simulation in Healthcare, IMSH, which begins this coming Sunday in San Diego, there will actually be a workshop. I'll be putting on a workshop with my colleague from Victoria on Monday afternoon on strategies for building an alliance. So if you're there, I'd love to see you. I'd love to meet you. Resources are the Society for Simulation in Healthcare, the International Nursing Society for Simulation and Learning, and AXL. Their annual meeting is in June. Both of these organizations have peer-reviewed journals. And in December of 2011, in the Society for Simulation in Healthcare journal, there is a paper on the evolution of a statewide network. And you can look that up, December of 2011. The NLN, National League for Nursing, QSIN, and the CSA are all good resources. There are multiple careers in simulation that are evolving. Faculty, obviously, is one of the biggest growing areas. Some schools actually hire simulation faculty, where others have their clinical faculty also do simulation. It just is all over the map right now, but there's a huge opportunity for faculty. Simulation technicians are a huge growing sect of the roles that are emerging. Simulation technicians, that is a best practice model. It used to be that we did not use SimTechs and we expected the faculty to do all of the technical pieces of the mannequin and the control room, and we learned quickly that it is not a good use of a faculty, and so this whole simulation technology role has emerged, and the CSA is actually working on some simulation technician curriculum that will be launched this year in 2016. So look at administration. There's opportunity to be a coordinator, a manager, a director, and even a researcher in simulation. So that summarizes the Alliance part of the webinar. I just wanted to give you a taste of what was out there. Some of these alliances are still going on. All of the ones I talked about are. Some have failed. There have been some who have tried and they haven't had good leadership or funding to keep them afloat. The CSA is 8 years old and it is still alive, and there has not been $1 of grant funding. We have leveraged the funding of the initial BASC, and then the rest has been part of our sustainability plan, which has been revenue from our courses, our consulting, our industry partners, our scenario sales, our apprentice program, etc. And we just launched a mentorship program through the CSA, so stay tuned for that. So now I'm just going to segue into the University of San Francisco's Masters in Healthcare Simulation program. This is a 30-unit program which includes 540 hours of practicum. It is 100% online, and we have one conference per semester on campus in San Francisco, which is highly recommended that you attend. It is not mandatory. We cannot mandate that because we are an online program, but if you cannot attend, we can get you in virtually through Zoom. And if we have international students, if they can't come in, we will record it and send it to them. So it's online. It starts January 25th, 2016, which is a couple of weeks. We prepare students to become professional simulationists, whether they're an RN, an MD, or a technician. You do not need to have a clinical background to apply for this degree. You just need a bachelor's degree with a 3.0 GPA. You need transcripts. You need 2 letters of recommendation. And you need to apply now because we're starting on the 25th and we still have slots available. You do not have to have any experience in simulation. The only thing we ask, if you have no experience, is that you take an online medical terminology class before you attend the first online class. And that will be part of your assignment because there is a lot of, it's a different language in healthcare. And as healthcare professionals, we talk fast, we use a lot of acronyms, and we also have created an environment that it is okay to ask a question and say, time out, what are you talking about? We don't have any clue what you're talking about. And in our last cohort, the 2 non-clinicians learned pretty quickly some of the lingo in healthcare and have gone on to secure very good jobs in simulation. So I'd encourage you to apply now. What I don't have up here because it was just approved is our certification program. If by chance you're not interested in a master's degree, you can gain a certification in simulation in either education or management. So the first 3 courses that we offer in the curriculum would equate to a certification in simulation, and there is some practicum that goes on with that. The practicum is an experience in a sim center somewhere in the vicinity of where you live. It could be where you work, or it could be anywhere around the world where we have a contract with. And I can tell you, we just signed a contract with Australia. So for those students who are eager to do their practicum abroad, you could theoretically go to Australia on your own and get your practicum hours over there. So we're really going global. We're really trying to work with you on your practicum experience so that it's near your home. If you come to San Francisco, we have a sim center here, and we'd be happy to take any students as well. You might want to consider coming to that conference and staying for an extra week to get some hours in too. So that's just an option. So I think at this point, Jennifer is on the line, and there is a chat function, and I'd like to ask you to send me some questions, and she can facilitate those, and I can hopefully answer the question. So thanks for your time, and I look forward to your questions. Please chat away.
Can you hear me, KT?
Yes, I can, Jen.
I don't have any questions right now.
But you've got a phone call.
I do, sorry.
Oh, that's okay. So I see there's a couple of students on the line that we've already accepted for January 25th, and we're going to be communicating with you over the next 2 weeks. Stand by. We've got an online module for orientation that we're going to have you go through, which is very generic, just orienting you to the school, to Canvas, to the all the things you need to know about USF. And then the week of January 25th, we're going to have a more in-depth orientation virtually, and then open up the courses so that you can start working through some of your assignments. Any
have one
questions?
question here, sorry. Is the online master's program an accredited program?
The online master's program is an accredited program through the University of San Francisco School of Nursing and Health Professions. It is a non-clinical degree, so it does not warrant a nursing or clinical accreditation. But our school is accredited through CCNE and WASC.
And another question is, what is the application deadline for January 25th?
Well, how about January 23rd? We need to be able to read your application and accept you, but we are taking applications up until that day. And as I said, the week of the 25th is also going to be orientation. We're going to orient you to the library. We're going to orient you to APA style. So during that time, we can still admit. So the worst case scenario, everyone has to be enrolled in the classes by January 31st, but we need to have an interest prior to that so we can set up our courses accordingly.
That's all we have so far.
So our first two classes, one is a foundational class. It's the foundations of simulation as a teaching methodology. I will be facilitating that course, and it's really going to take you from the history of simulation all the way through what the standards are now, all the resources to kind of give you a flavor of everything you need to know, and then it'll go in depth into every other course, subsequent course. The other course is curriculum development and design, and that will be taught by Dr. Jared Cutson. And Jared is out of New York. He works in a hospital. He is the director of simulation lab at a hospital in New York City. He's also the co-chair of the International Meeting of Simulation and Healthcare, and he will be teaching it from New York. And those are the first two courses. We do have a wonderful curriculum, and I can read through the courses that are coming after that. I've got them right here. So the first three courses are the certification in simulation and instruction as an educator, and that's the foundational concepts, curriculum design, and creating an environment for pre-briefing and debriefing. Those three classes equal the certificate for teaching. In addition, you would have to get 2 units of practicum. And then we move on to evidence-based practice and research methodologies. We have a course on financial and project management, how to create a business plan and build a business case for sustainability of a simulation program, how to build a successful program, and those courses that I just named would be your certificate in simulation leadership. Then we have electives where you have to take one, either technology or a course on the future of simulation. So those are the courses, and then we have all of the practicum that goes along with it, followed by a capstone course in your final semester, totaling 30 units.
I do have a couple other questions that came in.
Okay.
How big is a cohort? One student wants to know.
So our first cohort that we ran last year was 4 students. And this year, our minimum is going to be 10. We have, I think, 8 or 9 right now. And so we're hoping that we're going to have 10 or 12. We'd like to keep it, we don't want to go over 20 in a cohort. We understand that this is our first group online, so I anticipate we'll probably have around 12.
And then another question is, will the orientation be broadcasted virtual since this is an online program?
Oh yeah, everything we do is going to be virtual going forward except for that one visit to USF. So we use Zoom as our platform for communicating, and it's been really, really good for us. It's zoom.us, and it'll be a virtual orientation where we'll have all the students there. You can see their faces, and you can get to know each other, and that's after you've taken the generic online orientation course for the school. Then we'll do one specifically to this group, and it'll be a virtual broadcast, if you will, and it'll be at a time zone that works for everyone. Unless we have international, then we'll have to work on that. But right now we have a couple of international students, and I think that there are 2 times that are adequate to use if you have international students, and so we'll probably offer these different broadcasts twice so that we can hit all of the students and we're not disrupting everyone's life.
We're also going to be recording them, the orientations.
Good.
Yeah.
Yes, so we'll record them as well and post them. Any other questions?
One more. Will all class materials be online downloadable, and will all or only some of the classes be live/Zoomed? What % is live versus self-study?
So I think it's going to depend on the faculty, but our goal is to have some interactive, synchronous experience at least every module. And my modules are 2 weeks at a time. So sometime within that 2 weeks, we'll pick a time and have a session where we're all talking to one another, whether it's a chat or a lecture or a guest speaker. The rest is online, and we use a lot of discussion boards. So we post questions, we want you to respond. We also have assignments, and they're all online, downloadable, uploadable. We have videos, we have, it's very multimedia oriented. Everything, this is our first time we're doing this all online. Last year we were a hybrid. We were online, and then we had the students come to San Francisco twice a semester. And although we really liked that model, the market is showing us that we really need to go more online. And so we are moving in that direction. So I don't have all the answers right now. I personally, as an instructor, need to have interaction with the student, so we'll make it happen in my class that we have some synchronous learning opportunities every 2 weeks.
Nothing else new coming in, KT.
All right. Well, we will be following up. You'll probably get an email from our recruiter just thanking you for being on the call. And I see a couple of you. I will see you online, and hopefully the rest of you will consider applying, or at least applying for our certification program. All right. Well, thank you, everyone, and I hope to see some of you in San Diego. Have a great day.